Yeah, we can see. Yes, right.
Sundar, can you see my screen?
Yeah,
Is it moving?
yeah, is it moving? Yeah.
All right, yeah. Hello, everyone. Good morning. My name is Prajwal. I'm one of the HIEM trainee. Today, I'm going to present on hypothermia and frostbite, and the curriculum number is EnvC3. So the objectives of my presentation today would be to discuss the epidemiology of frostbite and hypothermia, discuss the pathophysiology, establish the differential diagnosis, discuss about the investigation needed in the cases we face, and the management plan. So let me start first by defining what is hypothermia. So hypothermia is defined as a core temperature of less than 35 degrees Celsius. So further, hypothermia can be classified into three categories, that is mild, moderate, and severe. So like mild hypothermia is defined as the core body temperature of 32 to 35 degrees centigrade. And moderate hypothermia is defined as a core body temperature of 30 to 32 degrees centigrade. And also like severe hypothermia is defined as less than core body temperature less than 30 degrees centigrade. Usually like severe hypothermia, we rarely get in A&E department. So let me move forward. So like further, like hypothermia can be classified into primary and secondary hypothermia. So the mostly like the patient presenting to A&E would present with primary hypothermia. So what's primary hypothermia? So primary hypothermia occurs when healthy individuals are exposed to environmental circumstances. For example, like when the people go to hiking and mountaineering, and they are exposed to adverse weather, and also like when they go to swimming in a cold pond and river, and they are exposed to cold water immersion, that causes their body to like drop the core temperature and subsequently having the hypothermia. And going forward, like what is secondary hypothermia? So basically like secondary hypothermia occurs when there's a drop in body core temperature secondary to primary disease process, such as like when people drink a lot of alcohol and they're intoxicated, or also in the case of trauma, and in a case of myocardial infarct. So let me discuss epidemiology. So in UK, like it is estimated that about 6 to 8 patients per 1,000 patient get hypothermia every year. So usually like most cases occur in the urban setting and are related to environmental exposure, secondary to like alcoholism, it's usually seen in like drug user, and homeless people and mental illness. So like usually these people are really vulnerable because like in the drug addicts, they take drugs and then like they're unconscious, and they do not know like what state they are in, and that's why like it leads to like exposure to cold and leading to hypothermia. And also like homelessness people, like they do not have like a good shelter, and then because of the cold weather, like they predispose themselves to hypothermia. And also like people with mental illness, like they forget to take their regular medication, and also like they do not know like what they are doing, so they are also like exposed to cold weather, and like that leads to hypothermia. So going forward, primary hypothermia usually affects young males and infants. So secondary hypothermia usually affects patients who are elderly, homeless, mentally ill, and victims of trauma, and who have multiple comorbidities. So let me discuss about the pathophysiology of hypothermia and heat loss and heat production. So our body, like it maintains a core temperature of 36.5 to 37.5 by balancing heat production and heat loss. So if the heat production is less than the heat loss, then it will lead to hypothermia. So like how is heat produced in the body? Let me discuss that. So heat is generated by cellular metabolism at the rate of 40 to 60 kilocalorie per meter square of body surface area. And furthermore, like the heat production can be increased by 30 kilocalorie per meter square body surface area by contraction of the striated skeletal muscles, and up to 2.5 times the basal heat production rate. Shivering can produce the heat. So let me discuss heat loss. So 55 to 65% of the heat in our body is lost in the form of radiation. So this should be like important in the management of hypothermia, this concept. So conduction and convection accounts for about 15%, and rest is from respiration and evaporation. So when we are managing the patient with hypothermia, we should think about like the radiation of the heat from the body, so we can control that. So what's thermal? Another form of like pathophysiology in the heat production and loss is like thermoregulation. So usually the hypothalamus controls the thermoregulation via tooth pathway by the increased heat conservation and increase heat production. So like what are the clinical features of hypothermia? So like sometimes like severe hypothermia can mimic that. As the core temperature decreases, there is like a cerebral event and also like a cardiovascular event that like decreases. In about like 32 to 35 degrees centigrade, that's the mild hypothermia. Apathy, amnesia, ataxia, and dysarthria are the common features. And for the moderate hypothermia, that is the temperature less than 32 degrees centigrade, consciousness falls progressively, and this can lead to coma. There's hypotension, like there's arrhythmias and respiratory depression and muscular rigidity. So like in this patient, like with the moderate and severe hypothermia, this can mimic mimic that. So like when you were like resuscitating this patient and examining this patient, we should always like take care that like we need to feel for the pulse for at least a minute, because in a hypothermic patient it's really hard to like get the pulse. So we have to keep note that like shivering is an unreliable sign. So in the patient with like hypothermia, whose temperature is less than 26 degrees centigrade, like BT and VF may occur, and they're very vulnerable to VT and VF. So if they have like hypoxia, like even a slightest of movement can cause VT VF. So we should be very like careful on handling these patients. Let me go to like signs and symptoms systematically on the patient with hypothermia. So let me first discuss about the cardiovascular system. So in the cardiovascular system, like usually present hypothermic patient initially presents with tachycardia and vasoconstriction. That's the initial response to the cold stress, and that will result in blood pressure increase and cardiac output initially. So with the increasing hypothermia, bradycardia occurs, and in the body there's a oxygen demand. Oxygen demand decreases, and then the cardiac output falls. Eventually, it will lead to severe bradycardia and ventricular fibrillation, and subsequently asystole. So for the coagulation system, the patient with hypothermia, they are very vulnerable to like coagulation cascade. So patient with moderate to severe hypothermia may develop coagulopathy. So low temperature adversely affect the enzyme responsible for coagulation cascade. So this will definitely not be reflected in the laboratory studies such as PT and APTT, but they're vulnerable to coagulopathies. Going to the central nervous system, the signs and symptoms of central nervous system would be like impaired judgment and memory. As the severity of the hypothermia is worsened, patient will present with slurred speech, ataxia, and drowsiness may develop. And patient also may exhibit like food stamping and paradoxical undressing. So like I said earlier, in severe hypothermia, if it's not like managed properly, coma and death may result. So let me discuss about renal system. So initially, like there is a peripheral vasoconstriction that will lead to relative central hypervolemia leading to diuresis. And there's a more severe hypothermia results. More severe hypothermia results in renal failure and renal shutdown. So what happens is like due to exposure to like a cold and hypothermia, the peripheral there's a peripheral vasoconstriction, and which will lead to like central collection of the blood, which will lead to like hypervolemia and leading to a diuresis, and further like it will lead into hypertension. So we should be like careful in resuscitating a patient with hypothermia. So initially like we might not need like a lot of IV fluids, but later when we start to like warm the patient, we might need a fluid resuscitation. For the respiratory system, the initial response to hypothermia is an increase in respiratory rate and a resultant respiratory alkalosis. So, and as the body cools, the respiratory rate falls and the patient develops carbon dioxide retention and respiratory acidosis, and ultimately like it will lead to respiratory arrest. So what are the diagnostic measures of hypothermia? So we can diagnose hypothermia with tympanic membrane. Usually like it is recommended to use a rectal temperature with an electronic probe or low reading thermometer. In advanced cases, like if the patient is intubated in severe hypothermia, we can use esophageal temperature device as shown in the picture in the lower bottom here. Usually like here in our trust, so what we do is like we depend on the tympanic probe. So I was able to like ask one of the nursing in charge like if we have a rectal thermometer. Like unfortunately, like I was not able to get a hold of it. Otherwise, like I would have shown the picture of it. So basically, like what I was told was that like we use a tympanic temperature probe in our department. It is reliable. So like we can also like diagnose hypothermia with the ECG. So as you can see in this picture, like there is a rhythm disturbance of which shows like AF with the slow ventricular response, and there's a prolongation of QRX complex, and the pathognomonic sign of hypothermia in ECG is J Osborne waves, as you can see here. I can't. You can see it in the PQRS complex here, like in the rhythm strip 2. There's a J wave seen. So that's the pathognomonic sign of the hypothermia. So here. So there's also like ST2T wave abnormalities in the ECGs. So like I said earlier, so the diagnosis of the hypothermia may be also suspected by J Osborne waves on the ECG. So usually it's seen in lead 2 and V6 initially. So for the investigation, we have to like do the basic sets of blood such as U's and E's, FBCs and LFTs, and clotting screen. So including like toxicology, which includes alcohol level. The patient with hypothermia are like they are vulnerable to hypoglycemia. So we should also check for blood glucose. Amylase and lipase is like falsely elevated in this patient, which doesn't mean like the patient has pancreatitis. And also like we have to rule out any signs of infection. So we have to take blood cultures, and also we have to like establish the acid-base level and status of the patient by taking the EVG. Like I discussed earlier, we have to do the ECG just to see like if the patient like has any ECG abnormalities. We have to perform chest X-rays to look for pneumonia or any signs of aspiration. And for the older people, like after the rewarming, we have to suspect like if there's any fractured hip, because fractured hip can lead to immobility, and like that can predispose patient to hypothermia, cold temperature, and succeeding hypothermia. So we should consider a pelvic X-ray as well. So we need to consider CT scan if we suspect like any underlying head injury or stroke is suspected. So how would we manage hypothermia? So the basic principle is to treat in a room which is more than 21 degrees centigrade. So we should start by removing wet clothes, and we have to dry the skin to like decrease the heat loss. Like I said earlier, we have to handle the patient with very care and place it to cardiac monitor because patient with hypothermia, moderate and severe hypothermia, they are very vulnerable to cardiac arrhythmias. So initially, like we can start to make the patient warm and start with humidified oxygen by mask, and we should consider intubation if needed, and like we should start with oxygenation. So I'll discuss further about the management in my succeeding slides. So like initially we should secure IV access. Like I said earlier, like initially like fluid is least likely to be fluid is like really required initially. It's only like during our resuscitation, when we warm the patient, there might be like a thing called after drop. So in that case, like we can give a fluid resuscitated patient with warm IV fluids. So I'll be talking about after drop like in my succeeding slides. So in the unstable patient, we should consider CVP and urinary catheter. So for the patient with severe hypothermia, we should include ITU from the initial phase of the treatment. So like I said earlier, like warm IV fluid administration in an inefficient rewarming method and runs the risk of fluid overload and precipitating arrhythmia. So initially, like as long as patient is maintaining his or her BP, we should not start with warm fluid. If the patient like has a like hypoglycemia, we should treat it with IV glucose. So in cardiac arrest, like we have to think about few things. So we should give the CPR in the standard rates according to the ALS protocol. And also like heart may be unresponsive to defibrillation, pacing, and drug therapy. Usually, like it's said that in the patient who has hypothermia, which is less than 30 degree, patient are like not responsive to drugs, and like they are not so responsive to defibrillation. So the drug metabolism is decreased and unpredictable in this patient with temperature less than 30 degrees centigrade. So if we need to like give drugs during the CPR, we have to aim for temperature more than 30 degrees centigrade. And if we are thinking about giving the defibrillation, if we give like if we give 3 defibrillation and it is not succeeded, then we have to wait for the core temperature to be raised more than 30 degrees centigrade. So let me discuss about like rewarming methods. So there are the different kinds of rewarming methods, and it depends on the trust, like which where we are working. So in our trust, we only like use like warm IV fluids, the like space blanket and the beer hugger blanket as shown in the first 2 picture. And like I had a chat with like a few of the consultants regarding the peritoneal lavage as shown in this picture, but we hardly use like in our settings. So it's usually in the like higher trauma centers they use peritoneal lavage, and then also like extracorporeal rewarming as shown in this picture. So what are the methods of passive rewarming? So like it is an easy, non-invasive and suitable for mild cases of hypothermia. So for the hypothermia whose temperature is like more than 32 degrees centigrade. So the basic principle is it decreases evaporative and conductive losses by wrapping in a warm blanket. So we can also like think about if you don't have like the space blanket, a polythene sheet should be good enough to like reduce the heat loss by radiation. So like in our normal human being, like endogenous metabolism and shivering usually generates enough heat to allow spontaneous rewarming. So it's for the patient with mild hypothermia. So usually like if you're resuscitating the patient, we have to like aim for a rate of 0.5 to 2 degrees centigrade increase per hour, because like in the elderly patient, it can lead to like hypertension, and it can further lead to like cerebral pulmonary edema. So we should be careful about this. So let me discuss about active rewarming. So active rewarming can be given by a warm water bath at 41 degrees centigrade. But this is not applicable if the patient is receiving a CPR, and also if the patient is requiring airway care such as ventilation, the monitoring is very difficult. So hot water bottles and heat pads are less efficient and can cause burns. So it's not ideally advisable to do this kind of method. So what we can do is what we do in our trust. We can give a beer hugger blanket like shown in this picture. It's a hot air blanket, and there's a machine which will give some warm air and it will warm the patient. So another method is core rewarming. The few of the methods for the core rewarming is peritoneal baths. You can also what you can do is via catheter. We can put 45 degrees centigrade warm saline into the peritoneal cavity and leave it for 10 to 20 minutes, and then replace it with fresh warm supply. You can do it for 2 hours. And what it does is the warm fluid directly hits the liver and blood in the IVC. And other method of core rewarming would be pure cavity irrigation, stomach, or bladder irrigation. So there's also a method known as extracorporeal rewarming. So it's usually used in the higher centers. We do not have this in our trust. So usually in the extracorporeal rewarming, it rewarms the patient blood by cardiopulmonary bypass that maintains the brain and organ perfusion. So if it's available in the patient with severe hypothermia and in the patient with cardiac arrest, this should be the choice of rewarming method. So usually it rewarms the core temperature at the rate of 1 to 2 degrees centigrade per 5 minutes. So it's a very effective way of rewarming the hypothermic patient. So we should be careful while resuscitating the hypothermic patient. There might be an after drop. So basically after drop is the fall of patient's core temperature after the initiation of the warming. So what happens is during the initial phase of rewarming, the peripheral sites and the abated vasoconstriction result in the return of the cool blood to the central circulation from peripheral circulation. So when the cold blood from the peripheral circulation return to the central circulation, it will lead to further hypothermia in the core. So this will cause temporary worsening of the physiological parameter, and it will also predispose patient to a dysarrhythmia or cardiac arrest. So we should be very careful about after drop. So initially, after we start our treatment, if there is an after drop in the blood pressure and then other parameters, we can resuscitate patient with some warm IV fluids. So let me discuss about Frostbite. Usually the Frostbite occurs in the tissue at the sub-zero temperatures. So what are the predisposing factors to frostbite? So it's basically in the patient with homelessness, drug addicts, it's inadequate clothing and footwear. So hypothermia also can lead to frostbite. And people under the influence of alcohol and drugs, they have a high chance of getting frostbite from the cold temperature, cold weather. And people with the peripheral vascular disease have a high chance of getting a frostbite as well. And smoking and previous cold injuries can also predispose patient to frostbite. So frostbite usually involves the extremities, especially the finger, toes, nose, and the ears. So it's usually also seen in the people who are doing high altitude climbing. So frostbite can be classified into superficial and deep. Superficial and deep. So basically superficial frostbite, it affects the skin and subcutaneous tissue. And in the deep, in addition to the skin and subcutaneous subcutaneous tissue. Let me discuss about frost nip. So frost nip maybe skin of the nose, face, and finger goes white and numb, but recovers rapidly on protection from cold and with transient paresthesia. So in the frost nip, there is no tissue loss or no permanent damage. So frost nip can be managed in the field by just rewarming, like, protecting the area of the frost nip, and it does not need like medical attention. However, like a frostbite can have like a bad consequence, so needs medical attention at the hospital. So let me discuss about superficial frostbite. Superficial frostbite involves the skin and the subcutaneous tissue. Usually the frozen area is numb and looks white and waxy. So usually the tissue feels firm, hard, but are still pliable, and rewarming is very painful. So we should consider like giving IV or like oral analgesia, like when we are rewarming the patient. So NSAIDs is the choice of medication in the rewarming patient during the rewarming phase. So the skin also becomes like edematous and hyperemic, and it also becomes like motile or purpur, which serums feel blister. I'll show you a picture in my for the succeeding slides. And after like 3 weeks, there may be a hard black scar formation. And as this separates, it will reveal a red, shiny, healthy skin after 3 weeks. So this is a picture showing like frostbite with a clear vesiculation, example of superficial frostbite. So let me discuss about deep frostbite. So basically, deep frostbite involves muscle, nerves, and sometimes bone, as well as the skin and superficial tissue. So the damaged area is hard and remains gray and white after rewarming. After like a few hours, like there may be blood-filled blisters that will develop, and subsequently the dead tissue mummifies and then separates after several weeks or months. So this is like one of the example of a deep frostbite, severe frostbite with early hemorrhagic vesicles. So this is one of the example of early appearance of severe frostbite of the hand after like initial treatment. The purple color and absence of blister after the treatment is a very unfavorable prognostic sign. So like this is also like example of severe frostbite of the foot. A purple color and absence of blister are very unfavorable prognostic sign of the frostbite. So this is like a example of severe frostbite of hand and feet. There's a in the picture, like you can see like dry gangrene, which are clearly demarcated, and this will lead to like further like significant tissue loss. So what's the mechanism and pathophysiology of the frostbite? So when the like patients are like exposed to the cold weather, the arteriovenous anastomosis in the skin suck blood away from the acral areas to limit the radiative heat loss. So after this, like the tissue temperature drops below 10 degrees centigrade, and there's a development of anesthesia. So due to this, like there's a subsequent endothelial cell leak, plasma will leak, and there's like a microvascular constriction in the place. So there will be further crystallization, no crystallization is seen, and the deeper tissue conducts and radiate heat. And as the temperature like continues to fall, there's a like formation of ice extracellularly, causing water to exit from the cell and including the cellular dehydration, and that will lead to like hyperosmolarity, collapse, and death of the cell. So this is one of the example of like severe frostbite after the treatment. So like this looks like a normal, almost a normal skin, but like it can be like a very deceptively benign. So let me discuss about the treatment of frostbite. Treatment of frostbite like usually varies from the situation and the facilities. So only for, like I said earlier in my presentation, only frost nip should be treated in the field. Frost-beaten tissue need rewarming as soon as possible. So like to further stop the damage from the freezing. So like if we have a patient with frostbite in the emergency department, like how do we approach it? So like we have like a pre-thaw, thaw, and like post-thaw phase. So let me discuss like individually. In the pre-thaw phase, like we have to access Doppler pulses and appearances of the like patient's like extremities, and we have to like protect the part. We should not like friction massage the area to rewarm the area, so it can lead to like catastrophic damages. So the first like principle is like the patient with frostbite, they might be vulnerable to like they already might have a hypothermia, so we need to treat hypothermia before frostbite. And we also need to like address any medical and surgical condition if like there's any factors involved. And like if the patient is hypovolemic, like we have to like give some fluid resuscitation as indicated. And like during the thaw phase, like we have to provide a patient with opiate analgesia as needed. We can also give ibuprofen 400 to 600 mg or aspirin, because like when we start thawing, it can be very like painful like treatment. So we have to thaw the patient by immersing the like extremity, like the part of the injured body part into circulating water at 37 degrees centigrade to 39 degrees centigrade, and it should be monitored by thermometer. So we should also encourage patient to like have gentle movement, but like I said earlier, like we should not do like any massage. So after the like thaw phase, like it comes post thaw phase. So we have to do like dry up the extremities, and then like we have to elevate it. So like if there are like a clear vesicle, then we need to aspirate it. And if there's there's a broken vesicle, we can apply like some topical antibiotic or a sterile aloe vera ointment every 6 hours. And we need to leave the hemorrhagic vesicle intact. So if there's like a tetanus indication, prophylaxis indication, we have to give it. And if there's like patient is vulnerable to streptococcal like infection, then we should also give like a prophylaxis. And in severe cases, we have to like give alpha blockers such as phenoxybenzaimine. And if we think like the case is severe enough, then we can perform angiography. And like if there's a positive finding in angiography, then if thrombolysis is indicated, we should start thrombolysis. And just to like have like a comparison like in the future of the development, we can obtain the photographs with the patient's permission. So like let me discuss about like one of the case study like which was published in like American Journal this. I got this from the ResearchGate. So basically this was like a rewarming of the refractory accidental hypothermia using extracorporeal membrane oxygenation. So like this was like done on a 45-year-old female. Let me just zoom in. Okay, this was done on like a 45-year-old with Down syndrome who was brought to ED due to high lethargy by caregiver. And initially, like when the patient was brought in there, like the patient had GCS of 8, BP of 94 by 47, and heart rate of 30, and saturation of 94% at the room air. So initially, like they started by like doing the vitals. So the patient was like initial temperature was around like 25 less than 25 degrees centigrade. So at like 1840, they started with warm saline via central line, and like during this time, like there was a junctional rhythm of 30 seconds. Patient was lethargic and on but responsible, and like further atropine was given. At 9:08, like after like a few like bags of saline, elective intubation due to declining mental stages and airway protection, it was done. At 1912, there was a PEA and there was a code, and CPO was started. Further, like warm saline was given via NG tube, and the core temperature like increased to 28 degrees centigrade. And like patient was started on like inotropes. at 1950, like there was no gag reflex, no corneal reflex, dilated pupil without light reflex. They were not able, the doctors were not able to like what do you call declare the brain dead due to hypothermia, and CPR was continued. Like I said, like we can't, like I said earlier, we can't claim the patient to be dead, declare patient to be dead if the core temperature is like less than 30 degrees centigrade. So we have to rewarm the patient to up to like 30 degrees centigrade just to declare death as well. So like ECMO consult was done for rewarming, and like initially echo was done, and there was no cardiac activity, and CPR was continued. So at 2040, like ECMO was started and CPR was stopped. So total CPR time was 88 minutes. So on the telemetry, there was agonal rhythm, and the body core temperature was 26.8 degrees centigrade. So the inotropes were discontinued, and as soon as the ECMO was started, so the circuit temperature was initially set at 37 degrees centigrade, and the initial map was maintained at 65 mm of Hg with the ECMO flow of 4 liters per minute. So after 20 minutes of ECMO, the EKG showed junctional rhythm of 60 seconds. At 2240, arterial waveform showed a cardiac activity. And at 2350, there was like core body temperature was around 36.5, and echo showed normal cardiac function, and patients started to like follow commands. So at 00, patient was started on weaning trial of ECMO, and then the BP was stable at 100/58, heart rate of 100, and a saturation rate of 99% without any inotropic support. So at 125, ECMO decannulation was done, and total ECMO time was 3 hours and 45 minutes, and the patient was transferred to ITU. And CT was performed, and CT was like a normal, CT head was normal, and patient was extubated on the day 3, and patient was like transferred to floor on the 23rd day, and patient was discharged home with the baseline mental status on the 60 day. So yeah, this is the one of the case, like I got it from American Journal. So yeah. So like what you have to like consider while like severe hypothermia is like nobody is dead until they are warm and dead. So these are my references: Oxford Handbook of Emergency Medicine, Arkham Learning, and Rosen Emergency Medicine. Yeah, that comes to the end of my presentation. If you have any question, please proceed. Thank you so much.
Thank you, Prajwal. If we have any like question, we can discuss.
Prajwal, I wanted to like touch base on the hypothermia kind of in cardiac arrest stage. You've excellently presented well. It is like the last bit was the gist of everything. Covered the frostbite really well. In terms of cardiac arrest, what have you known about? What should we do? When should we wait? And when can the medication be given at what sort of interval? Because there are like set criteria where when we need to intervene by medical treatment in cardiac arrest.
So like what I have learned, like I went through like few books, and that during the cardiac arrest, we should give medicine like only if the temperature is like more than 30 degrees centigrade. So usually the medicine are not effective if temperature is less than 30. So the first aim is to like bring the temperature like more than 30 degrees centigrade or like equivalent to 30. Then we can think about the medical treatment.
So Prajwal, I learned it's a very good presentation. So can I add something regarding the like questions? So basically, if you go through like Google, like special CPR or ALS in special circumstances, so they have clearly mentioned that like as you already mentioned that it should be the pulse should be checked 1 minute. Okay, there is no doubt on that. and the medicine or the CPR continue, the target temperature is more than 30. What they mentioned about the like drug that is mostly administered due to the CPR is like adrenaline. So the adrenaline should be administered double time. Double time means if you are giving 3 to 5 minutes, then the double will be time, like 6 to 10 minutes. So that's what Surata was asking. And one more thing, like if we are giving CPR to the hypothermic patient, then we need to continue CPR, not interrupted CPR. They've changed that one as well. And then like as and CPR could be prolonged, and we can't decide like dead as soon as we like lost the pulse or something. So that's what they have made the change on that. And one more thing I would like to add, like regarding the classification of hypothermia. So if you go through like the NICE guideline, they've also added like profound hypothermia, that is less than 20 degrees centigrade. And there will be no severing if the temperature is less than 32. So this is all about like they have mentioned in the like special circumstances CPR and the new changes in NICE guideline as well.
Okay, thank you so much, Sikandar, for your input.
Surada, anything you want to add?
Regarding what you said, Sikandar, you're quite right. It's quite an interesting case that I've actually sent in the chat link, and it's quite interesting. It's basically based on whatever we have discussed today. So it would be really good, refreshing kind of how do I say, like a review of the topic. And it mentions that you wait for the defibrillation until 30 degrees Celsius. Meanwhile, but there, the argument is you do the shock first or not. So when necessary, feel like it's necessary, up to 3 shocks can be given before 30 degree, but until and unless temperature reaches 30 degree, you don't try. So how it is written basically in some of the articles is shock VF up to 3 times if necessary, then temperature is more than 30 degrees Celsius. Basically, your heart is in a state where the shock is not even felt properly. So if you are having no output from that shock given to VF, you still continue to increase the temperature. I understand that even the hospitals would not be able to do the chest drain and everything. I have seen in these district hospitals where there are like good senior support, actually done a bladder catheterization with a warm fluid, basically through a 3-way catheter. Second thing is you pump and kind of keep that fluid going in and out, the warm fluid going in and out. And another one is the peritoneal lavage as well. So at least the chest and the bladder can, this is more like a life procedure. And technically speaking, we never see ECMO happening anywhere apart from the IT. So I think a good of yourself should be what exactly in ECMO, how to connect it, do we, I mean, what else can we do about it? Because unless you think about it, you feel like, okay, I'm gonna refer to ITU and then ITU will deal with it. However, based on how, you know, clinically sound you are or how far you want to go regarding understanding the topic itself, was summed up by your last research article that you presented, which is excellent, because still there are certain doubts about like what is the ECMO flow, 4 liters per minute, what exactly is stopping ECMO in between hours and 2 hours. But I think everybody of us should be actually looking in any of the video presentation or anything like that about ECMO, because it's quite an important topic for any of the resuscitation that happens in ITU most of the time.
Okay. Thank you, Suraj.
Okay.
Excellent presentation, Prajwal.
So
Yeah.
I think we still have got some time. So I would like to add something more on regarding the hypothermia, if it is okay. Like if somebody is coming with like hypothermia, so we need to think about the like prognosis. So the poor prognosis most of the time associated with if somewhere like in the like drowning cases, if they are coming with like a hypothermia. So the in case of the drowning with hypothermia, the poor prognosis should be like if submersion or immersion is more than 5 minutes, and if initially when they need like a basic life support more than 10 minutes, and if like somebody coming to the ER emergency department with the like continuous CPR, and if you need to give the CPR in the emergency department, that will be a very poor prognosis. And one more thing, like GCS. So if GCS is less than 5, that will be a very poor prognosis. So that's what I know about the new things regarding this hypothermia. And one more thing I would like to add, like regarding this, like your frostbite classification. So I think there is some changes in the frostbite classification as well. So as we said, like superficial and deep frostbite. So now they have started classification like first degree, second degree, and third degree, fourth degree. So they make the change there as well. So like I would like you to go through those things. Otherwise, it's a very good presentation. Thank you.
Yeah. So Sikandar, can you explain more about the frostbite, if that's okay? Like, what is it?
So, yeah. Frostbite, like, the frostbite is like basically it's they have classified like a first degree. So first degree state that like if there is a hyperemia with some edema. Okay.
What's your resource, and can you share it if you have a slide or something like that? I want to know if that's okay.
But I think I've gone through like some FRChem. So I exactly have written somewhere. Okay. Fine.
It will be really like helpful for everyone if you can share your source, and if you have a slide, that would be wonderful, or like any article.
That's what so I think I think this is from I don't know the source basically, but I written in my note. They have like the changes there like in the, so it could be from FRChem intermediate, or it says from like
okay.
So I think
my sources is from Oxford Handbook of Emergency Medicine and Rosette.
Exactly. Yeah.
It's like right, our Bible. Right. So I don't think like I would consider other sources like other than that for now. So unless like you can show it, show us some like sources. You're
basically, you're absolutely right. So, but I just wanted to like know about this, that the classification has been changed. So yeah, definitely we are following the like Oxford Handbook, but there are some changes in the as like.
But I'm sorry. This frostbite classification is in our CHIEM learning and also in exam questions. So I think it is relevant. And the frostbite will be divided into 4 degrees, and first degree it will be just the color change like hyperemia, edema. You can't see any skin necrosis. In the second degree, you can see vesicles, but vesicles are clear. And in third degree, there will be vesicles, but it will be hemorrhagic. And the fourth degree, it will involve the skin, muscle, bones, everything. So this will be in questions. So you need to know that.
So this is
from learning.
I don't know the exactly source, but I have written in my note. So it's from Arkin learning.
Thank you so much.
Always there.
Yeah. Thanks, Prajwal. Thank you so
much. Always hiding the answer.
Thanks for the
very long time to see you.
Yeah, good to hear your voice too, guys. Thank you so much, Prajwal, for that beautiful, lengthy topic. I really enjoy hypothermia as a topic. When I was preparing for my FChem exam, the intermediate and the final, it's one of the topics I like because you can branch into dermatology, into bones, you can jump into cardiovascular with it. There are so many aspects of it that can come out in the exam. And I'm so grateful for the academic discourse between you guys now. The little bit of, I would say argument, but I would say discourse. And thank you, Roshanthi, for clarifying things. So these are questions that come out in the exam, and thank you, Roshanti, for clarifying it in the 4 stages of classification. The only thing I would have added, Prajwal, is, you know, your teaching today was fantastic. It was detailed, it was textbook. You know, you went through everything. It would have been nice if you interrupted it a little bit with questions and ask people, you know. So like these questions now, so if you think like maybe when you are asking, you could have just done an MCQ. So who knows the classification of burns, who knows you know, the drug treatment. So instead of explaining everything from beginning to end, which was detailed, it would have been good to break it maybe 3 times or 4 times, wait and ask people questions, let people interject, just to, you know, keep. But apart from that, it was textbook, you know, and it was very helpful. Thanks.
Thank you, Olu. Like I'll consider that in my future presentation. Thank you so much. Yeah.
Okay, so we finished with early, like our first session is finished early. So we have like second session. So we'll have a 5-minute break. We'll start around 10:50. We have a presentation with the Assis. So we'll start at 10:50.